We now move on to the next session on liver regeneration. I would like to welcome the chairpersons for this session, Dr. S.P. Misra, Dr. K.R. Palniswamy, Dr. Harshal Gadikar, and Dr. Ravi Rathi.
Good morning, everybody. We'll start the first session with Dr. Shiv Sareen, concept of regenerative hepatology and current status of stem cell, hepatocyte transplant, bioartificial liver, and bioengineered mass. Sareen, sir.
I would just like to announce that we are starting our parallel sessions in Hall B.
Good morning, and thanks for giving me a difficult topic, Akash, and he asked me to. I'll try and share with my colleague, Dr. Anupam, who is the chief of the regenerative lab, bring greetings from ILBS, except I have nothing to disclose. The topic given to me was too big, so I'm just covering regeneration in health and disease. So let's say health. So this is an old diagram just to tell you that, and remember this, the blood comes from the portal vein, goes to the central vein and the heart, and the direction is this. Bile and lymph, they flow in the different directions, and the life of hepatocyte is about 120 days. Earlier concept was all the regeneration occurs in canal of Herring, and this was Marcus Grompe's work, but now has changed. Once we know that it is the central vein and hypoxia which is the cause, and you have these diploid hepatocytes pericentral, and you can see these diploid cells, and they are annexin 2 positive. So last 10 years the focus has changed to the central vein. There are 3 tiers of liver regeneration. First, as I showed you, hepatocytes, then you have non-parenchymal cells, and then the immune cells. It is built up on the hepatic progenitors. We do not know every hepatocyte. The concept of stem cells does not exist for last 5 years. So every hepatocyte, especially around the portal vein, could be progenitors. And the third tier is the bone marrow and other organs. Let's look at simple partial hepatectomy model, 70% or so. Now the amount of liver left is very small, but the blood flow is same, causes high shear stress, development of nitric oxide, and the first cell to work is the sinusoidal endothelial cell, which in future will lead to development of IL-6, TNF-alpha, and Kupffer cell activation. So here is what happens, the L-sex. This is a beautiful paper in Science. So the moment you have hepatectomy, this is the induction phase, day 1 to day 3. The angiopoietin 2 levels go down. This leads to increase in cyclin D1, and TGF beta is blocked. So the TGF brake has to be broken by angiopoietin 2 for cells to enlarge. The day 4 onwards is the angiogenic phase. Then you have started with an increase in angiopoietin 2, VGEF2, and Wnt2 increase, and then you have L-sec proliferation. So the journey is like this. You have first hepatocyte loss, which proliferate, then you have L-sex. Now just see how beautifully there is an orchestra playing. So the Kupffer cells will start with complements, and then it is stimulated by LPS, and you have TNF and IL-6, and the hepatocytes go into proliferation stage. So I have told you about the immediate events. Then you have the hepatocyte priming, I showed you that. And hepatocyte priming has 4 major players: cyclins, the, the capacity of the hepatocyte to de-differentiate comes up, metabolic adaptation, there is a transient steatosis, fats, and metabolic inflexibility, changing to fatty acid and oxidative phosphorylation. Why should the liver continue to grow? It is the integrin kinases which stop it at day 7. So first is this initiation, induction, and then proliferation. Then you have hepatocyte priming, and then finally the orchestra plays that you have non-parenchymal cells also coming. And the major players are in circulation, bile acids and others. You also have a major player, the stromal derived factor, which comes from bone marrow, and several cytokines come into play. Let's say this paper, it is days and baseline increase. Immediately after hepatectomy, the stem cell factor is the first to go up, followed by GM-CSF. GCSF and erythropoietins are not markedly increased. This is our own data. Post liver transplant, when you have lost about 700 grams of liver, the regeneration becomes more, and the first of the players to come is IL-6, TNF-alpha, and hepatocyte growth factors take longer time. So cells and cytokines play together. Now this is an animal experiment, but I want to share this because this is the concept of annexin to pericentral hepatocytes. So normally the repair is done by pericentral cells. If the damage is more, then some of the portal vein area cells will come up. If the damage is chronic, the portal area takes over, and slowly in chronic severe damage, the whole of the orchestra, including the ductular cells, will come into play. So let me summarize. In normal liver or even in acute liver failure, the first repair is at zone 3. If the injury is mild, moderate or severe, different players come in, but this is a coordinated maturation differentiation orchestra. What is liver injury and liver failure? Liver failure is when regeneration is less and injury is more. And all the 3 tiers, first, second and third, they all have failed. Then only you have liver failure. Now, this is not a complicated diagram, and I want you to pay attention. Severe acute liver injury. The first player, is in the bone marrow. There is a hematopoietic stem cell and mesenchymal cells. They all come into the blood. So phase 1 of severe injury is bone marrow response. The second phase, this is most important, all the Stewart Forbes data now, Birmingham, is necrosis clearance. What happens in necrosis clearance is this. The cells are dead, but they are not cleared. So the replenishment of the Kupffer cell by the bone marrow derived macrophages to clear. If your bone marrow is weak, you will not clear the debris, DAMPs and PEMs. Others I have already told you, the hepatocyte priming. The fourth step is the self-replication, and then fifth is HPC activation. The whole now regenerative therapy is based on clearance of the necrosome. Now macrophages are the one, this beautiful gut paper this last year shows how do you clear the necrosis and clear the hepatocytes to proliferate. So if your macrophages are able to clear the dead cells and also you have eosinophils coming there, your liver will start regenerating. And you also have macrophages which are alternatively activated, AMPs, alternatively activated macrophages. And these alternatively macrophages, they will clear the dying cells. Suppose you have poor macrophages, you have to add macrophage therapy to improve regeneration. So decrease in necrosis clearance by macrophages compromises cyclin D1 required proliferation and increase P21 replicative senescence. This was our original concept about a decade ago. So there are 3 tiers which I showed you. First is your normal static liver, but then there is a mild injury. I have shown you most of it, how the IL-6 comes and starts the replication of the hepatocytes. Stromal derived factor, angiopoietin-2 initially increases and decreases and then it increases. Now comes the second tier, which at that time was the progenitor cell, which is now not correct. It starts from the central. But what is still very clear is the role of bone marrow, tier 3, clearing the damage and the paracrine signals and remodeling of the extracellular matrix. Now this is a very new and good concept. You have patients with cirrhosis, there is a scarring, and this scar inhibits the regeneration. So to start regeneration, you have to remove it. It's not easy. Second, your cells are in replicative senescence. They replicate, but they don't produce. They have lost the proliferation. We have to change this. The third area is the efferocytosis. Here is the macrophage and here is the hepatocyte which is damaged. If your macrophage can clear this debris, the hepatocyte which is dead, you will start regeneration. But if you can't clear it, nothing will happen. This is our data of the past. Hepatocyte proliferation is a major regenerative response, is abrogated in ACLF. Now see, this is ACLF. The hepatocytes are hardly proliferating. All these brown dots. ALF, it is increases. And you will see that the progenitors come into play, but not hepatocyte. Here, the hepatocyte proliferation is lower in ACLF. Now, this is another ongoing work. ACLF clearance of DAMPs and PEMS, the infection part. So, efferocytosis in healthy is 93%. Compensated cirrhosis, 56% of the cells are clear. Decompensated, 15%. And in ACLF, only 9% of the macrophages clear. So there is a defect in macrophages in clearing the debris in the human beings. This is another paper recently published in a very beautiful way. What fails first, liver or bone marrow? So here a CCL4 animal, we are giving in these animals over the period, and liver regeneration goes on. You have healthy fibrosis, bridging fibrosis, liver regeneration goes on. Then there is suddenly a regeneration failure when decompensation starts. But what happens in bone marrow? In bone marrow, in very beginning, in 3 weeks, MSCs have gone and long-term hematopoietic stem cells are already gone. They are gone before the regeneration failure. So the message is bone marrow fails before the liver failure occurs. So the second concept in the chronic liver injury is that the monocytes and macrophages, they are coming from the bone marrow. So you have monocyte derived Kupffer cells, MDKC. The MDKCs, they all come from bone marrow. They are the ones which will clear the dead cells. However, if your macrophages are bad, your hepatocyte proliferation will not occur. I hope I can clearly convince you on this. So way back, about 8 years ago, we used to do bone marrow in all cirrhotics before regenerative therapy. This is the normal liver, and you have a normal marrow which produces stem cell factors, which produces angiopoietin-2. So here you have Schwann cells, you have the MSCs, and you have HSCs. This is normally going. In early cirrhosis, there is a stressed marrow. More number of cells are coming, more number of adrenergic stimuli are there. However, in late cirrhosis, there is more of TNF, there is more of toxins, and metabolic imbalance occurs. Finally, let's say child C, you have an exhaustion of the bone marrow, and HSCs and MSCs have gone. So if there is a exhausted bone marrow, you don't have hematopoietic cells and niche cells in cirrhosis. So these are two landmark papers which was on the cover of Hepatology and later on to say that in a cirrhosis, your bone marrow autologous is exhausted. How can you correct it? So in the animal model, we did a work on the bone marrow. So a healthy animal mouse bone marrow was placed into a cirrhotic animal. It's a bone marrow transplant in a cirrhotic animal. What it did was, it was able to have an increase in donor cells which continued till day 21, then they disappeared. But during this phase, they were able to restore the hematopoietic stem cell reserve, accelerate regression of fibrosis, and these transplanted cell from a healthy marrow. So the basic concept is, why don't you do a bone marrow transplant rather than a liver transplant? What happens to macrophages? Why do they get exhausted in this? Here is the bioenergetic failure of monocytes. So this is only to show you the two tests. You have the basal respiration and extracellular acidification. So the oxygen consumption rate in these monocytes in ACLF is exhausted. And the mitochondria are damaged, the number of mass of the mitochondria is decreased, and therefore your cell have a bioenergetic failure. Secondly, the OXPHOS which drives phagocytosis is gone, mitochondria are less, and glycolysis which drives oxidative burst is also reduced. This is a paper under review. This is not a complicated diagram. This is ACLF which we think right now. So the first step, as I told you, is the bone marrow. The second step is again the non-clearance of the cells. The third is the replicative part from the hepatocyte. Fourth, you have a senescence because of which the CXCR7 and IDI and HGF signaling is gone down. And finally, the replicative phase and the cyclin, they are not working too well. So let me summarize this part. Is liver regeneration going on in ALF, ACLF and cirrhosis? Yes. But it is impaired. Why? The mitochondria don't have the fuel, hepatocytes are in senescence, LSECs are not there, they are already fibrosed, stromal cells have from bone marrow and liver have gone, and your macrophages are poor. They are all growth factor deficient, the marrow is depleted, and we need to supplement. You can do it by growth factors, by bone marrow transplant, and by MSCs. So what does a bone marrow cell therapy do? To cut it short, clearly you have to remove the damage. Necrosum has to go away, and this is an everyday affair. Then you have to provide a paracrine support from the matrix. Then you have to rescue the lost cells and you have to remodel the extracellular matrix. What does GCSF do? It works on the bone marrow, it traffics all your cells, HSCs and others, and it brings them into blood. It decreases the apoptosis in the bone marrow. Once these cells come into the blood, they will go to the liver, may cause regeneration, HPCs, paracrine, decrease fibrosis and inflammation. The dosages can vary. Now I would say 75 to 150 micrograms, and you can depend, a person may need 4, 6 or maybe more dosages. This was the initial learning for us. GCSF was able to mobilize compared to normal ACLF where 30% of the cells were showing CD34, post GCSF were 70% with a survival advantage. You can combine GCSF with erythropoietin or darbepoetin, which gave a survival advantage compared to placebo in decompensated cirrhosis. What this dual growth factor therapy did, increased CD34 and CD133 positive cells. Can every patient be given? No. You have to be sure that the patients have no advanced disease, their marrow will be exhausted, they should not be septic, hemoglobin should be good, creatinine should be less, otherwise you wait. This is the paper from the West, from Engelmann and the Easel group. They say GCSF doesn't work, but see what the patients they included. They had hepatorenal in 64%, HE in 62%, and had sepsis in 56%. And sepsis is a contraindication for therapy. We had just recently published that in alcoholic hepatitis, if you combine steroid plus GCSF, we call GPRED study, you may have a better survival than you have steroid alone. Mesenchymal stem cell therapy, I have very limited time. MSCs are master regulators, and this is a concept which I would like you to share. You have ACLF. In ACLF, monocytes are gone. There is a bioenergy failure. There is a functional exhaustion, and you have to resuscitate your monocytes. You can do it by umbilical cord MSC therapy. You can transfer the mitochondria from MSC into your monocytes. Your innate immune cells will become better and the paralysis can go. Transfer mitochondria from the umbilical cord MSCs. Now this is Stuart Forbes' beautiful work. You can do macrophage therapy, and he has now shown very recently, elegantly in first was phase 1 and now it is the phase 2. This is phase 2 just published. They only say that macrophage therapy can be beneficial, it is safe, but it doesn't change MELD. But it opens a window for us. This is our novel approach, which I will just share in a second, that instead of doing liver transplant, do a bone marrow transplant. I'll summarize. Very few carry home messages except stimulating your mind. In healthy liver, self-proliferation. In ALF, self-proliferation plus progenitor cells. ACLF, you have hybrid hepatocytes, HSCs and bone marrows can help. In cirrhosis, certainly you will have bone marrow and you have stem cells. I haven't spoken about a spleen, which stimulates, releases splenic inhibitory factors which have to be removed. How do you modulate and use it in practice? Some of the growth factors. You can use MSC, you may use macrophage therapy, but the journey has just begun. I also have more questions than answers, but thank you, and I invite you on behalf of APASL to Beijing. Thank you.
Thank you, Dr. Sarin, for the excellent talk. We shall take up the questions at the end. Move on to the next talk, the role of gut microbiota in liver regeneration in ALF and after hepatectomy by Dr. Suk.
Thank you. Thank you for introduction. Thank you for inviting me to this nice place in the APASL STC. So this time I will talk about the microbial influence on liver regeneration. So I will talk by this order. So liver disease, regeneration in liver disease, microbial influence on liver degeneration, and conclusion. So liver disease. As I told you, so liver disease consists of fatty liver hepatitis, liver cirrhosis. In case of liver cirrhosis, 5-year survival rates are very low. And the etiology, so microbiota has a major positive of the etiology. So in liver disease, so liver disease is reversible, and the liver disease in the pathological findings, so inflammation is important. So inflammation increased steatosis and steatohepatitis, and decreased in cirrhosis. So according to the inflammation response, so fibrosis increased from the steatohepatitis. So in the past, it has been thought that the cirrhosis was never reversible. However, now there can be reversal of fibrosis. Microbiome is a community of microorganisms that can be found living together in any given habitat. So there is a bacteria, a microbiome, and a virus. They are all have a harmony environment. So microbiome is a complex ecosystem. It consists of more than 1,000 species and more than 1 kilogram. So various factors such as NICU exposure, delivery mode, breast milk or formula milk, or antibiotics usage affect to the microbial variation. There is a bidirectional communication between gut and liver. So microbiota can be changed by our food and other things, obesity and choline diet and alcohol uses. Microbiota can use can be the dysbiosis, and the microbiota relating metabolite so modulate and control so inflammation, regeneration, and the fibrosis of liver. So microbiota and dysbiosis. Dysbiosis can be called dysbacteriosis. Is characterized by a disruption to the microbiome, resulting in an imbalance in the microbiota, changes in their functional composition, and the metabolic activities or shift in their local distribution. As I show you, so ALD and MASD patients has different types of pathophysiology. Dysbiosis is a key factor on the pathophysiology of the liver disease. So regeneration in liver disease. Dr. Sarin explained this part, so I will show you this briefly. So many liver injury cause the inflammatory regulator excretion and activate the hepatic stellate cell. It causes the health liver to the fibrosis to the cancerous liver. As a compensatory response, there is a liver regeneration. Priming signal, interleukin-6, TNF-alpha, starts the priming phase, and the other factors can be used in the proliferation phase. In the termination signal, TGF-beta is important. So, multiple signal molecules such as Wnt, beta, catenin pathway, HIPO-EF pathway, HGF pathway, Notch pathway, EGFR pathways are related to the liver regeneration. They regulate the hepatocyte proliferation, survival, and the tissue repair in the liver injury. Dysregulation and the impairment of this pathway lead to the impaired liver regeneration and the delayed wound healing. So in under the publication shows that there are so many signal pathways in liver regeneration after injury. There is activation of MET and the EGFR related signal pathway, and the CCL5 related pathway, and the interleukin 33 related pathway, and finally cholesterol supplementation related pathway. So, regarding liver resection, many patients with liver degeneration or liver disease require therapeutic liver surgery, such as hepatectomy, and then liver regeneration following hepatectomy holds significant value. Liver surgery needs to administer antibiotics as prophylactic drugs. So, antibiotics usage causes changes in gut microbiome and its metabolites. Gut microbiota is important in various pathophysiology functions. So I call that liver gut, liver axis. So the development of novel tools for evaluating and predicting liver regeneration based on gut microbiota has emerged in this field. So I will show you the liver regeneration after partial hepatectomy. If a patient gets a partial hepatectomy, there is some pathophysiology, tissue ischemia and hypoxia, increased shear stress, and the portal pressure elevation, and the plate function abnormality. These pathological factors cause the hepatectomy-related liver regeneration. If patient do the partial hepatectomy 1/3, and then there will be a hypertrophy of hepatocyte. If a patient get the partial hepatectomy 2/3, and then there will be a hypoplasia regeneration. If a patient get the 30, 80% or 90% of hepatectomy, there will be a de-differentiation and re-differentiation. I will show you the microbial influence. Okay, first, as I show you here, portal vein pressure elevation, microbiota relating factors are related with the regeneration after partial hepatectomy. So, the microbiome is different according to the disease the phenotype. So in patient with NASH, there is increased bacteroidetes and decreased Prevotella. In patient with liver cirrhosis, Enterobacteria is increased, Streptococcus is increased. Liver cirrhosis with the patient, hepatic encephalopathy patient, shows the increase of Bayonella. Hepatocellular carcinoma patient shows the increase of the Actinobacter and Verrucomic bacteria. Each liver disease has typical microbiota composition and ratio. So however, this ratio and the elevation and the decrement is different according to the ratio and the gender and phenotype of the disease. So as I told you, so each cirrhosis patient and the cirrhosis-related complication shows the typical microbiota phenotype and the decreased microbiota typical phenotype and increased, decreased typical metabolite phenotype. You can use by phenotype in the diagnosis and prognostic value as a biomarker. So gut microbiota and metabolite can be used as non-invasive biomarkers for the diagnosis of cirrhosis and its complication. So gut microbiota and metabolite are changed during and after liver regeneration. So as I see, the permucutase levels are decreased according to the regeneration progression. So after the partial hepatectomy, so at the time permucutase is increased, however, slowly decreased. In the pro-reporter phase, so bacterodetes are increased, increased. According to the response of bacterodetes, so microbiota relating metabolites such as cellulose, butyrate, and the tryptophan in the compounds are recovering the barrier function and metabolic homeostasis and the immune responses. In partial hepatectomy, permucutase also decreased, bacterodetes is increased in the proliferation phase. At the termination phase, so these changes restore the initial composition and attain a distinct composition. So microbiota composition also changed according to the time progression. So in the partial hepatectomy patient, it shows the different types of metabolic pathways. As you see, so here the DNA replication and the mismatch repair, RNA degradation, and other export purine, other metabolism are increased in partial hepatectomy patient. These metabolic pathways are different according to the time procedure, time steps. So gut reverses in liver regeneration, there are important factors in the eubiosis. So there is a flavonoid, interleukin-6, TNF-alpha in the compound. If there is a partial hepatectomy, this compound goes to the liver and modulate and start the regeneration. In the situation of the dysbiosis, so this TNF-alpha, interleukin-6, LPS, interferon gamma cause the dysregulate and impaired regeneration. So dysbiosis leads to impaired regeneration. So LPS, gut microbiome associated LPS, and gut microbiome associated virus are important in the regeneration after partial hepatectomy. So you can prevent, you can restore the regeneration in patients with partial hepatectomy. We can use the probiotics, prebiotics, and then so oral antibiotics. Carefully, you have to evaluate the role of antibiotics because antibiotics are killing some microbiota. So it can cause the dysregulated metabolic component. So FMT can regulate this, the regulation. Colon resection can be one modality. Jump-free mouse can be used for the evaluation of the metabolic component. So we can use the personalized nutrition, FMT, next generation probiotics, phage therapy, postbiotics, prebiotics, and barrier function modulation. Microbiota manipulation affects liver regeneration. So in recent paper, they shows that dysregulation related the regeneration. Microbiota promote liver regeneration through the hepatic membrane phospholipid biosynthesis. In situation of eubiosis, so dietary fiber make the bacterial fermentation. Bacterial fermentation make the secrete the acetate. Acetate increase the synthesis of the lipid component. Membrane phospholipid is increased. Finally, liver regeneration is well done. So very liver regeneration can be done without the problem. So in the dysbiosis situation, bacterial fermentation is decreased and acetate secretion is decreased. So consequently, lipid secretion, regeneration is dysregulated. Short-chain fatty acid, especially acetate, required for the liver regeneration. Acetate-dependent liver regeneration is regulated by lipid synthesis genes. Reduction in short-chain fatty acid producing microbes numbers can delay the the early priming phase of the liver regeneration. In our editorial commentary, we found that antibiotics disrupt the microbial balance. It means that antibiotic use delays the liver regeneration. Reintroducing short-chain fatty acid producing bacteria restores the liver regeneration in mice. It means that this short-chain fatty acid producing bacteria can be a therapeutic potential. Specific microbiota alteration in mirror dysbiosis patterns seen in liver disease. It means that the specific microbiota alteration, dysbiosis, can cause the delayed liver regeneration. Microbiota analysis in liver resection patients could predict regeneration outcomes. It can be used as a avoid unnecessary antibiotics in patients with partial hepatectomy. We show the clinical trial previous findings. So in a previous finding, they used the symbiotics. They used many bacteria and the prebiotics. So they give this material to the liver resection patient. So the problem is, and the limitation is, they used these materials to the small number of patients, 19 patients. So this finding, so AST level and ALT level is significantly decreased in this study. In another meta-analysis, so 4 clinical trials are tried previously. Symbiotics are used in patients with partial hepatectomy. In a positive finding, relative risk of overall infection rate and difference in median duration of hospitalization stay are decreased compared with the other patients. In patients with symbiotics usage. In summary, microbiota affect the hepatic lipid metabolism through the gut-liver axis. The underlying mechanisms are poorly understood. Perturbations of the microbes serve as building blocks for membrane lipid in liver cells. Liver regeneration and survival after liver surgery is severely impaired. Physicians in the future to improve patient outcomes after liver surgery by modulation of microbiota or their metabolites. Conclusion. In the liver disease, microbiota and its metabolites played a central role in the liver regeneration. Microbiota reveals the crucial influence on liver regeneration as a potential metabolic organ. Thank you. Thank you for introduction.
Thank you. Now, I would like to invite Dr. Dept Shukla for a lecture on evolving therapies for cirrhosis through remodeling and or liver regeneration.
So I see we are a little bit late. Do we have a, or no, I can just move it like this. So we are all talking about advanced liver disease and acute and chronic liver failure. You all know the complications of cirrhosis. So why is cirrhosis important in terms of antifibrotic therapies? Advanced liver disease has been considered a major endpoint in clinical studies for chronic liver disease and antifibrotic therapies. And this touches a lot of what we just heard, has been considered an important aim in therapeutic developments. So what are, in a nutshell, causes and cellular mechanisms of fibrogenesis? We have the resting mesenchymal cells in the liver. We have several triggers, mainly targeted to hepatocytes, but also to several other cells, especially the immune compartment and the triggering of hepatic progenitor cells, which can also be detrimental if they are cholangiocyte-like and damage to the endothelium. We have a transformation of the usually quiescent fibroblastic cells to activated myofibroblasts. These produce the bulk of collagen and other matrix proteins, scar composition. They also have a reduced synthesis of remodeling enzymes, which are also produced by endothelial cells and inflammatory cells, and they increase the inhibitors of these matrix-degrading proteases, and the final result is a net matrix accumulation, and if that goes on, we will end up in cirrhosis. And cirrhosis and HCC have many common pathways, also as regards cytokines and certain fibrogenic growth factors that also can drive cancer development. Similar mechanisms we can learn from the liver, for the liver, are also operative in other fibrotic conditions, although there's differences, of course. So how can we inhibit fibrogenesis? That means the active progression of the disease. Of course, if we have effective causal therapy as exemplified in viral hepatitis B and C, we can suppress fibrogenesis and even induce reversal in some patients. And for most other cases, we need direct antifibrotic therapies in addition to all the therapies that we have heard about, especially the ones mentioned by Dr. Sarin. And these could work well in conjunction with the previous medication attempts. So these drugs would then act on the activated hepatic stellate cells and myofibroblasts. They would also act on the primary drivers like activated cholangiocytes and so-called M2 type macrophages of the bad type, the pro-fibrogenic type. And they would then result in a decreased net deposition of matrix components and an increase in fibrolytic activities, which are also mainly attributed to macrophages monocytes. And then if combined with hepatocyte growth stimulation, we might even achieve a reversal or regression of decompensated cirrhosis. And this is a very good forum now to potentially combine the efforts that we have heard about with direct antifibrotic therapies. So a very good example that shows that cirrhosis is reversible, at least in the child POA stage, is a study by Patrick Marcelin, a follow-up of tenofovir-treated hepatitis B patients. And as you can see here in the box, many of these patients, 96, had child POA cirrhosis at the onset of therapy, and in a 5-year follow-up, you can see that the range of people, there's no pointer as I see, but maybe I can, yes, you see here, F5 and 6 in the blue and in the light green colors, you see that there is a very significant regression in 70 out of 96 child POA cirrhotic patients by at least 2 stages of the 4-stage fibrotic scale, and that's very significant. With ongoing tenofovir treatment after 5 years in follow-up biopsies. Patients who had high BMI had a high odds ratio of progression compared to the ones without a high BMI, and compared to histological cohorts, also the rate of HCC development was reduced from the expected 2% per year to 0.8% per year. Of course, these kind of medications are very unlikely to be effective in inducing fibrosis, regression, or preventing the development of cirrhosis. Of course, we can prevent this by just cutting alcohol consumption to a certain degree, or by having a healthy lifestyle. These are very important measures that we should never forget. Also in advanced cirrhotics. So what about direct antifibrotic and potentially at the same time anti-cancer therapies? So we would address the cells that play a major role in fibrosis progression. And these drugs or agents or measures should be effective in all etiologies of liver disease, not just NASH, for example, by weight loss inducing therapies. So they should address the key cells involved in fibrogenesis. These are mainly activated fibroblastic cells, fibrogenic epithelia like the cholangiocyte progenitors, not the beneficial ones that cause regeneration, but the pro-fibrogenic ones, and M2 type macrophages. They should address key molecules that govern fibrosis progression, for example, the TGF-beta pathway, but at the same time, this requires organ and cell-specific targeting, especially in the case of TGF-beta 1. And therapies might be most effective when applied as combinations. We come back to that at the end. And they are usually context dependent, early, intermediate, or late stage, as we have heard about the growth factor treatment, for example. So this is an acute bout of inflammation in red. And what follows in a time-wise delay in green is a fibrogenic response, which is usually self-limited and reversible. This is a more protracted, ongoing, or waxing and waning inflammatory trigger that causes a subsequent fibrogenic response and accumulation of connective tissue, which is still, on the long term, reversible once the inflammatory trigger subsides. And this is the development of cirrhosis, for example, where connective tissue accumulates more and more, the inflammation dampens down at the end. So what about the so-called tensegrity? If we have excess matrix or scar tissue in the liver and other organs, this can induce more scarring in a self-saving attempt of the organ to survive at least in integrity, even if not in full functionality. So this is an example of a molecular mechanism that is related to tensegrity. So if the matrix becomes more stiff in an intermediate stage of fibrosis, the responding cells, this the cell membrane in blue here, can express certain integrins, especially of the alpha V beta 1 in myofibroblasts and the alpha V beta 6 in epithelial cell class molecules that sense the stiffness of the matrix by binding to the latent TGF-beta binding protein, which harbors TGF-beta in an inactive proform. When then these cells get stressed on the matrix, the integrins get stressed and release TGF-beta in its active form. And targeting these integrins is highly effective in advanced stages of fibrosis. And this is an example of cholangiocyte proliferation, cytokeratin staining. This is a rat model of secondary biliary fibrosis. So you see these activated biliary progenitor cells, which are fibrogenic by release of TGF-beta, etc. And they also bear the integrin alpha V beta 6. If you inhibit the integrin alpha V beta 6 on the surface that releases TGF-beta from the matrix, you have a very significant effect, even in later stages of biliary fibrosis, on the accumulation of collagen as exemplified by hydroxyproline here. So this is bioligation for 5 weeks in rats and a 4-week treatment of an alpha V beta 6 small molecule inhibitor. And a blocking antibody has had in the past a similar effect developed by Biogenidec, and there's 3 companies in the US developing small molecules against integrin alpha V beta 6, but also alpha V beta 1. There's overlapping activities. Alpha V beta 1 is expressed on myofibroblasts, so the double inhibitor is even more efficient. And especially, you might have heard about bexotegrast development by Pliant in California, and a phase 2A study in patients with PSC has just been concluded with at least positive signs of antifibrotic efficacy in PSC, which has been untargetable in a way up to now. So the extracellular matrix is very complex. This is a very simplified view of the molecules involved in structuring the matrix. It's not just fibrillar collagens, it's proteoglycans, it's so-called matricellular non-collagenous proteins, a whole network of complex molecules. What we know is that there is a fraction of so-called bad collagens of fibrosis that mediate a high degree of interstitial stiffness. These are especially collagens type 1, 3, 5, but also the interfibrillar interstitial collagen type 6, which in itself is a signaling collagen at nanomolar amounts for fibrogenic activation of the myofibroblasts. And these are also proteolytic fragments which, when accumulating, these molecules release that further promote fibrogenesis apart from tensegrity and stiffness. And the ECM can also harbor growth factors and cytokines, and when there is remodeling, these are released. So what happens if you take out one of the major structural collagens, collagen type 1? So how can you do it? You can do it with siRNA technology targeting the myofibroblasts. This is an example of an older paper with a very stable siRNA encapsulated in lipoplexes. And if you inject these go mainly to the liver, as you can see here, by near infrared imaging. On the left side, there is biliary fibrotic mice. In the middle, you have normal mice. On the right side, you have the classical CCL4-induced parenchymal fibrosis. You can see here that in the time course after injection, the particles and the mRNA or the siRNA accumulates almost exclusively in the liver. And you can see on the lower right side that the particles accumulate mainly in macrophages, Kupffer cells, but also activated myofibroblasts, and to a minor degree only in hepatocytes and endothelial cells. So there's intrinsic targeting to the fibroblastic cells. Now, if you give that to biliary fibrotic mice, the PSC-like MDR2 knockout mice, you can see here on the left side of each of the figure here, you will see the procollagen 1 expression is suppressed by a lower and a higher dose of the siRNA by 90 to almost 100%. If you look at the serious red morphometry, on the upper right side, you can see that the collagen accumulating in a, let's say, stage 3-like fashion is completely suppressed with only 2 weeks of treatment in an advanced stage. And you can quantify the collagen area, you can quantify hydroxyproline, you can also look at signs of liver injury. There's no liver injury, no kidney injury with creatinine values. You see that also if you knock out certain profibrogenic signals in activated myofibroblasts by a Cree-ERT system, completely identical if you knock out the TGF-beta2 receptor in myofibroblasts inducible, you get exactly the same results, and interestingly, inflammation is also attenuated. So we can disrupt fibrogenic pathways by taking out, in advanced fibrosis, key bad collagens. So what about the role of macrophages? We have heard about the bone marrow macrophages being very important in the regenerative response. A very important concept of fibrosis is that we have so-called hot and cold fibrosis. So we have cirrhotic patients with inflammatory infiltrations, and we have patients without these infiltrations. We have the cold scar and the hot scar, and only the hot scar is relatively easy to reverse because we have the cells that can dissolve excess extracellular matrix already in the scar tissue. Otherwise, it's difficult to get remodeling bone marrow-derived cells, macrophages, that can degrade connective tissue into the cold scar. So we need immune cells to remodel the cold scar tissue. We have to recruit them into the scar tissue, and burnt out cirrhosis is much more difficult to reverse than hot fibrosis with immune cells. So we would need repopulation of these cells as an additional strategy. So you have heard from Dr. Sarin a lot of stories about the relevance of bone marrow-derived cells and growth factors. I won't go into detail anymore. So what about the macrophages and their direct activity on scar resolution versus progression? In the test tube, you can produce so-called M1 type macrophages, which are the classical pro-inflammatory phagocytotic, the active, Macrophages, they cause mild inflammation, but they are antifibrotic because they release fibrolytic enzymes. On the other hand, you have the macrophages of wounds that do not heal, the M1 subgroup of so-called M2 type macrophages, and they release pro-fibrogenic factors for myofibroblasts. So macrophages of wounds that do not heal, like you have in chronic fibrotic conditions, advanced fibrosis, are pro-fibrotic, and you have to switch them. How can you switch them? And that's one of our major aims. Experimentally, is a targeted modulation of these M2 type macrophages in the scar tissue, but also in HCC towards M1 type macrophages. This is an elusive type still, and there are certain signals and certain signatures of these macrophages that indicate these are pro-resolution macrophages. And we want to switch them, for example, with siRNA or antisense therapies. One switch I want to show to you, it's not published yet by us, it's C-FOS. It's a transcription factor, very unusual for an antifibrotic therapy. It's mainly upregulated in fibrogenic macrophages, fibroblasts, and these pro-fibrogenic cholangiocytes. So really the target population relevant in fibrosis progression. So FRA2 transgenic mice expressing that in all cell types are prone to fibrosis, skin, lung, and what we also found, severe biliary fibrosis. They just overexpress in every cell. So what happens if you induce FRA2 inhibition with lipoplexis or antisense oligonucleotides directed to the liver non-parenchymal cells? As you can see here, FRA2 is very efficiently knocked down in vivo in fibrotic livers, be it biliary fibrosis experimentally or parenchymal fibrosis. What is very smashing here is, and just look at the heat maps of 3 groups of mice, biliary fibrosis on the left side. These are replicates of 3 animals, 4 identical replicates, but showing the homogeneity of the proteomic study. This is a proteomic analysis of whole livers, 3,000 proteins quantified, healthy controls you see here, and here you see the treated animals on the right side, and these have got a pattern with late stage treatment with the antisense or siRNA that is identical to normal compared to the fibrotic signature. So it completely reverses many signatures relevant to advanced fibrosis on the protein level, not just on the NGS or RNA level. And the same effect you get with antisenses that go to the liver automatically and non-parenchymal cells as you get with lipoplexis. And just in the last couple of minutes, I want to show you another type of nanoparticles. These are polymer nanoparticles that are biodegradable. So they are removed from the body within a couple of days and release their message or their cargo into the liver specifically after IV injection very efficiently. So you can package many different things into these nanoparticles. They have a 100 nanometer diameter, go mainly to the liver. As you can see here again, here is an example of a bisphosphonate, which you know for therapy of osteoporosis. Of course, you can't use a bisphosphonate for liver disease because 99% goes into the bones. But bisphosphonates are very interesting for repolarizing macrophages towards a fibrolytic phenotype. And as you can see here, if you package that into these nanoparticles, almost all material goes into the liver. These are the nanoparticles here, loaded with alendronate. These are controls. I don't know why this went back. I have 3 or 4 more slides to show. I don't know how I can go to these now, otherwise. Okay, I will show you this kind of, no, it doesn't work. So maybe I'm stopped, then I have to stop now. Sorry for that.
Thank you, Dr. Shupan. Sorry for the slides over there. Dr.
Okay,
Koshi,
I
sir.
will promise you I will come to the end. I won't show you treatments for hepatocellular cancer. And I will just summarize. We now can directly address the extracellular matrix by specific therapies, including nanoparticular therapies. And these drugs also affect hepatocellular cancer, which I couldn't show you due to very tight time constraints. And major target cells are activated by fibroblast cholangiocytes and M2-type macrophages. We can approach or address many otherwise untargetable targets with siRNA antisense or nanoparticular packaging, and which I can show you. There is very good non-invasive serological markers of fibrogenesis and fibrolysis now, and some of these therapies can be tested in phase 1b proof of concept studies using these biological markers of progression or reversal, and such studies are on the way. Thank you.
Thank you. Dr. Koshi, should we start with the questions? So it's open, sir. Dr. Sareen, sir.
Yes, please ask your
Dr. Sareen.
Yes, questions to Dr. Sareen, Suk or Shupan. Sareen, there's a question.
Sareen, sir, you had a very good concept of the bone marrow. If the bone marrow has a bioenergetic failure, how does the GCSF and erythropoietin work over there if this failed over there? And will it be possible for you to put in some healthy mitochondria through macrophages or aldronate, as Dr. Shupan has said, and then give these two drugs?
Yeah, bone marrow is useful for whether it is heart, kidney or liver for repair. But in heart, kidney and other diseases, bone marrow is normal. But in liver disease, the bone marrow gets exhausted much earlier because of the continuous cycle of cytokines, and the bone marrow is the second side of the coin. You will recall in the fetal life, the blood is made by the liver. So liver and bone marrow share almost all stromal cells, hematopoietic cells, mesenchymal cells. But they get exhausted before in bone marrow than in the liver. So how to repopulate? There are two ways. One is to give external macrophages, hematopoietic stem cells. You can do it by umbilical cord. Then when you give umbilical cord MSCs, they transfer their mitochondria into the into the bone marrow macrophages, and they go to the liver. You can regenerate that by using that approach. The second approach is you can use externally generated macrophages, what Dr. Stuart Forbes is doing. However, it is very primitive. In my opinion, the best method is to have hematopoietic stem cells come up in the bone marrow, which will make monocytes, macrophages, and other cells. The two ways of doing it is, one is by giving erythropoietin or by GCSF. But this is an exhausted marrow. So we should start while the patient is in F3, F4 fibrosis to regenerate bone marrow. To start when there is already cirrhosis is too late.
So one more question, sir. Has anybody seen that, we all know that liver transplantation works very well. Has anybody seen that after liver transplantation, the bone marrow goes back to normal?
After liver transplant, bone marrow does not get well. It is very well, it is clearly seen, and that is why your sarcopenia, muscles do not come up. So reverse pathway is very, very poor. The forward pathway, bone marrow replacing by better cells, is a better pathway.
Will be a dual transplant of a bone marrow transplant and liver transplant are necessary?
Well, dual transplant has the challenge of the autologous versus allogenic. So if you give allogenic transplant to the bone marrow, you require all those cells. So a better method could be try to stimulate the senescent hepatocytes in the liver The senescent hepatocytes in the liver can be stimulated by bone marrow, by stromal derived factor, or by stem cell, and these are now getting ready. SDF is getting ready for use, clinical use. Stem cell factors are getting ready to use, and the augmenter of liver regeneration, ALR, is also getting ready for use.
Any experience with aldronate, like he said?
I don't have any experience of that, but I would say it is a tough area. Just cytokines won't work, just macrophages won't work. It is the niche, it is the environment. If the environment can be corrected, the senescent cells can grow up. But the environment is so toxic, so inhibitory. The TGF beta is so strong, so you need to have TGF beta inhibition so that the fibrosis is regressed and the regeneration can be stimulated.
Anybody else? Any questions from the audience?
I know it's a tough topic. It is very difficult, and therefore I would like everyone to have a good cup of coffee. And I have one question, if you allow me, to Dr. Schupan. Detlef has been working for almost 3 decades, and you said a bad collagen and a good collagen. So how, just without the inhibitory RNAs, siRNAs, how can you have a good collagen rather bad collagen? So what is this concept of good, and you were the discoverer of the undulin. So where are we on the good collagen?
So I think it's all context dependent. Of course, collagens are there because they are important. They keep the structure of the organ when they are not excessively deposited. Once you have scar formation, they become the bad collagens because they, in a way, eliminate the possibility of healthy regeneration. And that's what occurs in cirrhosis. So if there is an overdrive with the chronic inflammation, the chronic M2 type macrophage activation that drives that connectiocytes.
What's a good collagen?
Pardon?
What is a good collagen?
For example, a better collagen are certain basement membrane collagens. They can also be
I4.
Collagen 18, collagen 15, and collagen 4. But also, that depends on the amount and the quantity and the contextual environment. So what we can show...
To put it in simple terms, how do you study the collagen turnover, deposition versus dissolution?
That, of course, I plan to show in one slide. We have serological markers, now very good markers, much better than 10 years ago, in the serum that can reflect the buildup or the removal of certain collagens, including the interstitial ones, potentially the bad ones in advanced fibrosis, but also basement membrane collagen, but also, even more importantly, much better indicators of progression, matricellular proteins, which are non-collagenous, and one key protein here is thrombospondin 2. It's a very good indicator of progression.
Okay. All right.
Any other questions from the chairpersons or from the audience to any of the three speakers?
Dr. Earlier we know, long time back, when I was a student, we thought that collagen 1 is reversible, collagen 3 is not reversible.
Yeah, both are associated. Collagen 1 and 3 form fibrils together. Collagen 3 is a little bit more on the surface, and collagen 3 in the blood, the procollagen, is also an indicator of fibril growth and a certain not so good marker of fibrosis progression. So the fibrils are composite fibrils. The major structural component of the big cables is collagen type 1, but there's collagen 3 in the fibrils, collagen 5, and there's interfibrillar collagens like collagen 6.
So can I briefly interrupt and ask, is there a ratio of M30 to M65 or procollagen 3 peptide to, everyone measures procollagen 3 peptide, your ELF has that procollagen 3 peptide. So is there any relevance of, because for all of the other people, the common sense is, how do I measure? So M30 to M65 or procollagen 3, peptide, is it worth measuring?
So M30 to M65 plays a role in MASH or alcoholic liver disease, but not so much in other liver diseases. So there are, if at all, indirect fibrosis markers for metabolic or alcoholic liver disease. Pro-C3 is a little bit a mixed bag. It also reflects inflammation when more Pro-C3 is released, or procollagen 3 peptide. And that's the reason why we developed within the big litmus consortium novel biomarkers of progression and reversal. And they appear to be more directly reflecting what's happening in terms of fibrosis progression and reversal. Much better predictive values.
Okay. One question to all the speakers. Are there any drugs in pipeline for liver regeneration or fibrosis resolution other than the causal treatment of liver disease?
Maybe Dr. Suk can tell us.
Dr.
Any
Shupan
drugs?
actually mentioned some which are in the pipeline for
I think so.
fibrosis reversal.
Yeah, so
Are there any other questions from the chairpersons or from the audience?
Maybe I may ask or a microbial expert, what about acetate treatment? What about treatment with the other short-chain fatty acids, butyrate, propionate?
oh, yeah. So I did not publish the paper. However, I have experience of butyrate propionate also have an anti-fibrotic effect. So I think do you have to broaden the evidence, the experiment? You have to do that experiment, and then I can say about that. However,
So should we drink vinegar?
Anita?
Yes. We
or
should
acetic
drink
acid
vinegar.
Replenishment?
Coffee, sir.
Vinegar is a science paper.
Yes.
That science paper, the vinegar is the best one for you to regenerate. And I will ask Dr. Suk also. Your Penneth cell is your pacemaker for blood flow. And Penneth cell works only through the microbial peptides.
Yeah.
So Penneth cell is your pump, is a regulator of your blood flow to the liver, and that is dependent on microbial peptides. And therefore vinegar is the best one for regenerating and improving.
So what I would propose, maybe we can discuss it, to have a study. No one will pay for it. Substitute propionate, butyrate, and acetate in these liver-related, but also other chronic conditions. And I can tell you, I recommend patients, intestinal autoimmune patients, short-chain fatty acid supplements.
So don't drink alcohol, don't drink beer, drink Indian-made concoctions which are having full of vinegar.
Thank you everyone for the very interesting discussions. It's our duty now to just summarize it quickly, or the whole morning session. I'll try quick. ACLF, etiology is important, trying to remove it is important, and the stage is important in deciding what the outcome will be and whether transplant will help. And futility is also important to decide. And this, not only the stage, but Professor Raj Reddy mentioned that the organ which is involved is also important in determining futility. The lung is a bad organ when it is involved. As far as Patrick's take on managing chronic liver disease without transplant, he mentioned the importance of detecting and treating infection early and well, appropriately, removing alcohol, and organ support in keeping the organ going till regeneration can occur. As far as regeneration is concerned, Serene told us about the choreography and the ballet-like dancing of various parameters, the macrophages, the bone marrow, and other organs. But we are still not at a stage when we can really put it to clinical practice. Similarly, for dysbiosis, almost every liver disease, at every stage, there is dysbiosis of the microbiota. But again, we are not at a stage when we can really put it to practice. We know that except in spontaneous bacterial peritonitis, hepatic encephalopathy, we really don't use antibiotic therapy to modify the course of the disease. And as far as fibrosis is concerned, again, we have many potential targets which have been identified, as Dr. Shupan mentioned, but some are in early phases of trials, phase 2. A variety of molecules, siRNAs, are potential therapeutic targets, but we are still at an early stage. Is there anything else you'd like to?
Thank you very much. That's a very nice wrap-up of the whole thing, and thank you all the speakers for singing. Thanks a lot.
Thank you.
Thank you, sir. I would like to thank all the speakers and the chairperson also for joining us. We'll be taking a short break for tea now, and we'll reconvene at 10:30 for our next session.